Welcome everybody to today's webinar from the Consortium of Universities for Global Health. Today's webinar is on with Dr. Hank Tomlinson. Dr. Tomlinson is the Director of the Division of Global HIV and TB at the U.S. Centers for Disease Control and Prevention in Atlanta, and he'll be joined by his colleague, Dr. Susan Maloney, who's the Chief of Global Health in the branch within the division. Global TB within the branch of the division. I'm Dr. Keith Martin, the Executive Director of the Consortium of Universities for Global Health, and thank you for joining us today. So what is the #1 cause of death from an infectious disease in the world today? It is tuberculosis. Despite the fact that this disease has been around for thousands of years, TB still kills more people than any other cause of infectious disease. Any other infectious disease cause. It causes immense suffering. It's a huge drain on economies. Despite this, our treatments and diagnostics have not been kept up to the challenge before us. In addition, the disease affects the most marginalized people in every country of the world. It does not have to be so. We can make a change, we can turn a page, and we can get to a place in time where we will not have any deaths from tuberculosis. I should also say that the treatments can be very painful. They take up to 6 months, and oftentimes people fail to complete the course of treatment just because the treatment has so many side effects. As a result, it puts us into the risk for drug-resistant TB, extreme drug-resistant TB, and multi-drug resistant TB. But to talk about all of that, we have Dr. Tomlinson. I'm going to hand it over to him in a second. But before I do that, I just want to invite you that after Dr. Tomlinson finishes his presentation, there'll be a chance for you to be able to pose your questions. And in fact, get your questions ready, send them in the chat box, and you'll have a chance to ask those questions of both Dr. Tomlinson and Dr. Maloney. So with that, I'm going to hand it over to Dr. Tomlinson. Dr. Tomlinson, thank you very much for joining us today. Over to you.
Thank you, Dr. Martin, and thank you to the Consortium of Universities for Global Health for hosting us today and for this opportunity. Hi, everyone. My name is Hank Tomlinson. I'm the Director of our Division of Global HIV and Global Tuberculosis at the U.S. Centers for Disease Control and Prevention in Atlanta. So good afternoon to those of you on the East Coast, good morning or good evening to those of you in other time zones. It's my pleasure to be here with you today to discuss CDC's integral role in ending the global TB epidemic. In 2015, all United Nations member states adopted the 2030 Agenda for Sustainable Development, which consists of 17 goals that serve as the blueprint for peace and prosperity for people on the planet. Among these goals, SDG number 3 is to ensure healthy lives and promote well-being for all people at all ages. One of the targets for this goal, target 3.3, aims to end, among other health threats, the epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases by 2030. In the same year, the World Health Organization launched the End TB strategy. This strategy's vision is a world free of TB, and its goal is to end the global TB epidemic. The 3 main indicators for this strategy include a 95% reduction in the number of TB deaths from 2015 to 2035, a 90% reduction in TB incidence from 2015 to 2035, and 0 TB-affected families who face catastrophic costs due to TB by 2035. Although preventable and curable, tuberculosis remains the world's top infectious disease killer, killing 3 people every minute and claiming almost 2 million lives each year. A fourth of the world's population, almost 2 billion people, is infected with TB, and nearly 10 million of those become ill with active TB disease each year, including 1,100,000 children and over 500,000 persons with drug-resistant TB. TB is the leading cause of death for people living with HIV, or PLHIV, and each year there are about 251,000 deaths from TB among HIV-positive people. People living with HIV are 20 to 30 times more likely to develop active TB disease than people without HIV. And while only a small proportion of TB cases are among people living with HIV, In certain countries, the proportion of TB cases with HIV co-infection is as high as 70%. Drug-resistant TB is a deadlier, costlier, and harder to treat variant of tuberculosis. It's now found in every country. In 2018, almost 500,000 new cases of multi-drug resistant, rifampicin-resistant cases were found, and TB accounts for 30% of projected antimicrobial resistant disease and death. More than 30% of total estimated TB cases and 70% of the estimated multi-drug resistant cases remain undiagnosed or unreported each year. These missing cases result in continued TB transmission and contribute to substantial TB morbidity and mortality. Only 56% of diagnosed MDR TB cases are treated successfully. Low adherence rates, poor oversight of private sector treatment, and supply chain issues with drugs all contribute to not curing all patients diagnosed with TB or drug-resistant TB. This fuels resistance to more and more drugs. Better, shorter treatment regimens and drugs can improve adherence and reduce costs to the health system, engaging the private sector and ensuring that they use high-quality drugs. Given the devastating effects of TB on the individual and society, reducing TB, a curable disease, is named as one of the no-brainers in terms of benefit per dollar spent by the Copenhagen Consensus Center in 2015. Efforts to end TB are one of the best investments for improving global health and economic development. Inaction is more costly than ever, and a failure to act now could hamper global economic growth and stability and undo the progress that has been made against this epidemic. Reducing TB deaths by 95% is a global development best buy, with a $43 gain for every dollar spent. Governments of high-burden TB countries have recognized this, and they contribute 84% of the total global funding for addressing TB. The U.S. government remains the largest international donor. However, there remains a $2 billion shortfall to reach global targets. We're standing at a pivotal moment at this time for TB. The World Health Organization's End TB strategy has set bold and ambitious targets to reduce TB mortality by 95% by 2035 and reduce TB incidence by 90% by 2035 compared to 2015 levels. However, with current global trends, TB is projected to end by 2170, by which we will have seen over 1 billion deaths from tuberculosis. We can reach the goals for ending TB in 2035 by optimizing the use of current and new tools for all people through universal access to healthcare and social protection, by introducing the use of new tools such as vaccines, drugs, and treatment regimens for active disease and for latent TB infection, and through political will and supportive policies. We've made some strides in our TB control efforts, and we have reasons to be hopeful that we can reach TB elimination. This slide illustrates the progress and the momentum thus far. Since 2000, over 60 million lives have been saved through TB and TB HIV in treatment. TB incidence is decreasing by 2% per year. As of September 2018, CDC alone screened 6.5 million people living with HIV for tuberculosis. The global TB response has been bolstered by new diagnostics such as expert MTB-RIF, which contributes to the rapid diagnosis of TB disease and drug resistance. We have better and new anti-TB drugs and shorter treatment regimens that can improve adherence and successful treatment of drug-resistant TB, including bedaquiline, linezolid, and pertomidine. Diagnosis and reporting of multi-drug resistant TB have doubled since 2010. Promising new TB vaccines are now under development, and there is an increased political interest and commitment to ending the TB epidemic. In September 2018, the first ever United Nations General Assembly high-level meeting on tuberculosis, with more than 1,000 participants from around the world, assembled in New York City. The U.S. President's Emergency Plan for AIDS Relief, or PEPFAR, is working to provide TB Preventive Treatment, TPT, to 5 million people living with HIV by 2020. This effort is co-led by CDC. We must recognize, however, that we still have much work to do, and although new diagnostics and new drugs have already transformed some of our approaches to preventing, diagnosing, and treating TB, these are incremental innovations. Case finding and treatment success for TB and MDR TB improved in the past few years, but they are still far from acceptable. In addition to technical and scientific progress, political leadership and collaboration and multi-sectoral accountability are key requirements for success. During the UN high-level meeting on TB, UN member states unanimously made a commitment to diagnose and successfully treat 40 million people, including 3.5 million children, with TB by the end of 2022, and to provide TB preventive treatment to 30 million people by 2022 to protect them from developing active TB disease, including at least 6 million people living with HIV, 4 million children under 5 years of age, and 20 million other household contacts. The UN high-level meeting on TB resulted in the adoption of a political declaration on the fight against tuberculosis, which reaffirmed the commitment to end the TB epidemic by 2030 and included ambitious and bold targets for scale-up of TB diagnosis, treatment, prevention, and research. The success of the initiatives of the UN high-level meeting on TB hinge on funding, action, and accountability. The political declaration on TB calls for mobilization of $13 billion per year to finance universal access to quality TB prevention, diagnosis, treatment and care, and an additional $2 billion per year for research into new tools. Scale-up of TB care and prevention, as well as fast-tracking research into the development of new diagnostics, drugs, and vaccines, require rapid actions by countries, donors, and stakeholders. In May of 2019, WHO finalized the multi-sectoral accountability framework to accelerate progress to end TB by 2030. The Centers for Disease Control and Prevention is a major U.S. government agency at the forefront of fighting tuberculosis. CDC has made a substantial contribution to the progress in diagnosing, treating, and preventing TB both at home in the United States and across the globe. We have one of the strongest contingents of TB experts in the world who work alongside our partners to accelerate progress toward achieving the WHO NTB strategy targets. We utilize our strong technical expertise and our unique peer-to-peer relationships with global ministries of health and use our own and President's Emergency Plan for AIDS Relief or PEPFAR's platform to develop and catalyze innovation, data-driven approaches to find, cure, and prevent the disease globally, and to strengthen surveillance and laboratory systems critical for global success. CDC aligns with the End TB strategy, the PEPFAR strategy for accelerating HIV/AIDS epidemic control, the U.S. government's TB strategy, and the U.S. National Action Plan for Multi-Drug Resistant TB. Our mission is to provide scientific leadership and expertise for developing, evaluating, and implementing evidence-based and innovative approaches to find, cure, and prevent TB, as well as to build and sustain surveillance and laboratory systems and workforce and research capacity. We support the global epidemic response to TB in countries as shown on the map on the right. We prioritize and focus our resources on specific countries where we can apply core CDC strengths to maximize impact. CDC's priority countries are those with a high burden of HIV-associated TB, dedicated financial resources to implement interventions for HIV-associated TB, the political will to collaborate, and geographic and/or programmatic strategic importance. CDC's focus countries are those with a high burden of TB and multi-drug resistant TB. In-country CDC staff, political will to collaborate, existing or ongoing investment, and all significantly contribute to the U.S. TB burden. CDC's three focus countries are India, Vietnam, and China. To reach the global targets outlined in the NTB strategy, we must change the trajectory of the TB epidemic and bend, or even better, to break the TB incidence and mortality curve by addressing the drivers of this global epidemic, which include missing TB cases, HIV-TB co-infection, and drug-resistant tuberculosis. 40% of adult and 60% of childhood TB cases are missed each year. People living with HIV are 30 times, and children are 10 times more likely to develop active TB disease and to die from TB than others. Ending the TB epidemic in our lifetime will require more than stepping up efforts to find and treat TB disease. It will also require comprehensive epidemic response strategy and dedicated resources and action to both finding and treating active TB cases and simultaneously addressing the reservoir of TB infection through TB preventive treatment, which can reduce the risk of death by 80%. As mentioned in the previous slide, one of CDC's strategies is to find TB. CDC works to expand access to better screening, contact tracing, and diagnostic tools and networks to find missing cases. Children remain the most vulnerable groups for TB infection. Out of the 10 million new TB cases globally in 2017, 1 million occurred in children under the age of 15. At least 194,000 children died from TB, including children living with HIV who are more likely to die once infected with TB. CDC collaborates with national ministries of health, as well as multilateral and non-governmental organizations to implement policies and programs and conduct research that support quality TB and HIV prevention, case finding, and linkage to treatment for all children and adolescents living with HIV. We also contribute to the gathering and reporting global childhood TB and HIV data within PEPFAR. To name a few of our activities and accomplishments in preventing, finding, and curing childhood and adolescent TB and TB-HIV co-infection. As part of the Gates-funded Pneumonia Etiology Research for Child Health, or PERCH, study, we demonstrated that TB is one of the top 10 causes of pneumonia in children. In Kenya, we are identifying the fastest, most effective way to diagnose TB in children. We collaborated with multiple partners, including the Kenyan Medical Research Institute and Harvard University, to determine and optimize a feasible combination of non-invasive specimens for TB diagnosis in children. This study of 300 children with TB symptoms found the combination of less invasive stool and nasal wash specimens performed similarly to invasive TB tests, such as the collection of stomach fluid, that often require hospitalization and are rarely available in resource-poor settings. Our work in South Africa has led to the WHO guideline changes for treatment of drug-resistant TB among children. Our work in Mozambique and Uganda, we are implementing and evaluating approaches to household-based contact investigations to identify and treat children at risk for TB. We work with international organizations to contribute to U.S. national and international TB guidelines in children and adolescents. Most recently, CDC contributed to developing a roadmap for childhood tuberculosis, led updating of U.S. Health and Human Services pediatric TB guidance, contributed to the development of a blueprint for addressing gaps in childhood TB diagnostics, and informed revised childhood multi-drug resistant TB guidelines with partner agencies. We partner with the International Union Against Tuberculosis and Lung Disease to develop a Child and Adolescent TB Center of Excellence, which produces and disseminates a variety of resources. To advance CDC's second strategy for TB epidemic control, CURE, CDC optimizes treatment for TB and its drug-resistant forms, including identifying and evaluating better treatment regimens and expanding access to care and treatment. TB is the leading cause of death for people living with HIV. As previously noted, in 2017, 30% of deaths among people living with HIV were due to TB. People living with HIV are 20 to 30 times more likely to develop active TB disease than people without HIV. While only a small proportion of all TB cases are among people living with HIV, in certain countries, the proportion of TB patients with known HIV status is as high as 100%, as you can see in the blue bar graph. With our increased focus on TB screening and treatment as a routine part of care for people living with HIV, we saw TB notifications increase and deaths decrease between 2015 to 2017. There were 100,000 fewer deaths, equivalent to a 25% decrease. The PEPFAR strategy, doing the right thing at the right place at the right time, worked. Right-sizing our response and focusing on the highest impact interventions, the dramatic scale-up of ART, which also provides some protection from progressing to TB disease, certainly played a role. Looking at the pink bar graph, the number of notified HIV-positive TB patients on life-saving antiretroviral therapy has grown in recent years. In the 30 high TB-HIV co-infection burden countries, overall, 85% of the TB patients known to be HIV positive were on antiretroviral therapy for HIV. 8 of these countries, Eswatini, formerly Swaziland, Kenya, Malawi, Mozambique, Namibia, Papua New Guinea, Uganda, and Tanzania, maintained coverage of at least 90% in both 2016 and 2017. Treatment of HIV infection with appropriate antiretroviral therapy reduces morbidity and mortality rates among people living with HIV. As part of CDC's third strategy, Prevent, CDC, along with PEPFAR, is aggressively scaling up use of TB preventive treatment, or TPT, with our partner countries. From less than 15% uptake of TPT in 2016 among PEPFAR countries, the U.S. government is committed to providing TPT to every eligible person living with HIV in our programs by 2022. To implement TPT, CDC established an intra-division TPT unit to promote TPT as an integral part of HIV treatment programs. This collaborative effort developed a TPT implementation toolkit, cross-country experience sharing in TPT implementation, and technical assistance to country programs to increase and achieve TPT targets. Our 6-point strategy includes establishing country baselines, implementing the TPT toolkit, raising awareness, providing technical assistance, working in partnerships, and planning scale-up when appropriate. We have prioritized TPT within all PEPFAR programs with aggressive scale-up already underway. Ensuring appropriate policies are in place and procurement and distribution channels are streamlined are the most important initial steps in each country. No healthcare worker should become infected with tuberculosis simply by going to work, and no client should leave a health clinic with a new infection. Unfortunately, TB transmission has been well documented in healthcare and other congregate settings, which can become amplification points for transmission if infection control measures for TB are not rigorously and routinely applied. In 2013, CDC launched TB Basics, Building and Strengthening Infection Control Strategies, a collaborative global TB initiative that uses innovative tools and a mentoring model to assist countries with high TB, MDR-TB, and HIV burdens in assessing and improving TB infection control practices in health facilities using a continuous quality improvement approach. To meet the objectives of TB Basics implementation in TB-designated hospitals, a 3-phased approach is applied through workshops, implementation, and monitoring and evaluation. Expected outcomes of TB Basics implemented in health facilities will improve TB infection control environments, as well as encourage health workers to be more conscientious in promoting TB infection control. TB Basics emphasizes sustainable local capacity development and is being scaled up in more than 15 countries in Africa and Asia. CDC has unique experience in TB airborne infection control, healthcare epidemiology, and engineering and facility design. This combination of public health assets allows CDC to work globally to provide technical assistance to ministries of health to design and implement effective infection control policies, to build capacity for infection control through multidisciplinary trainings and mentorship programs, to design, implement, and systematically evaluate innovative strategies aimed at reducing TB transmission in institutional settings, to assist health facilities in establishing systems for monitoring disease transmission and incidence, especially among healthcare workers, and conduct operational research to build an evidence base for improved strategies and practices for breaking the cycle of transmission, and to translate science and evidence-based policy into public health programs. In our increasingly interconnected world, a health threat anywhere is a health threat everywhere. Core detection and response capabilities, as well as strong categorical disease programs, are critical to dealing with health threats, such as drug-resistant TB, and they require strong laboratory and surveillance systems, a well-trained health workforce, and the ability to respond to outbreaks as they occur. CDC is recognized for global leadership in program implementation, as well as public health system strengthening and capacity building, especially in surveillance and laboratory systems. We work with our national counterparts to strengthen the capacity of national and subnational TB laboratories to diagnose TB and multi-drug resistant TB, and have been leading efforts to analyze and optimize placement of expert machines for both TB and HIV program use. CDC has developed a dried tube proficiency test assay to evaluate expert testing performance and is actively transferring this technology to multiple countries to assure program sustainability in the future. CDC has also developed a robust laboratory quality improvement and accreditation mentoring program, SLAMPTA, strengthening laboratory management towards accreditation, and SLIPTA, strengthening our stepwise laboratory quality improvement process toward accreditation, that are both building strong laboratory networks across Africa and Asia. Finally, PEPFAR and CDC are sharing their expertise and our experience in data collection and data utilization to drive better programs with our national counterparts. We work to strengthen TB surveillance systems, to support scale-up of electronic TB databases, and conduct drug-resistance surveys. In numerous countries, we are also helping to develop local capacity to use data for decision-making, identifying hotspots, targeting interventions, and increasing program impact and cost-effectiveness, tailored to each of these localities' needs. For one example, in India, the ELEVATE program, which stands for Engaging Local Experts to Validate and Analyze TB Data to End TB, was launched in 2018 in Mumbai and is now scaling up to other Indian states. So what's next? We need to invest in game changers to end TB. We need innovation on the scale that we've seen in HIV, polio, and with other health threats, on a scale that outmatches the bacteria and ends TB. We need true, rapid point-of-care diagnostics that can be used in the most remote settings. We need tests that work on sputum, blood, breath, urine, and saliva. Better understanding of who of the 2 billion infected with TB will progress to active disease and why is critical to developing vaccines and other prevention strategies. Laboratory, clinical, and programmatic work is underway to better understand the pathogenesis of TB. CDC is specifically working to identify biomarkers for progression of infection to disease. The number of drug and vaccine candidates in the pipeline has more than tripled in the past 20 years, and that pace must continue until we have 21st century tools for TB. Development of optimal regimens will shorten treatment, reduce side effects, and that's crucial. We need a 10-day regimen that treats all forms of TB. Much of this work remains in the realm of the private and the nonprofit biotech sector. CDC works closely with the National Institutes of Health, the U.S. Agency for International Development, the World Health Organization, and other partners to evaluate treatment regimens and develop guidance on appropriate use of new and existing drugs. Although much progress has been made in TB epidemic response globally, much more needs to be done to achieve the ambitious end TB targets. The mission of TB epidemic control can be accomplished through a strong partnership and collaboration among donors and implementing partners, communities, and national programs. I'd like to thank my colleagues in the Global TB branch and in the Strategy, Policy, and Communications branch, and Dr. Tony Al, from the Division of Global HIV and TB Office of the Director for their collaboration in developing this slide deck. Thank you very much. Dr. Martin, back over to you.
Thank you very much, Dr. Tomlinson. That was outstanding. Folks on the line, please get your questions ready, and we'll take them shortly for both Dr. Tomlinson and Dr. Susan Maloney, who has just joined him there on the screen that you can see her. I would say that please come to our conference. CUGH has an annual conference. It'll be in Washington, D.C. next year. April 18th to the 20th is the conference. On April 17th, the Centers for Disease Control and Prevention are going to run a half-day satellite session. It'll probably be on global health security. During the conference, we'll have Dr. Tony Fauci from NIAID and others talk about emerging infectious diseases. So please come. You can register now at cugh2020.org. I think, Dr. Tomlinson, you did an outstanding job of looking at the arc we have to do for prevention, detection, and treatment for tuberculosis. You show that this is truly a best buy for a top 10 killer in the world, showing the $43 of rate of return for investing just $1 into TB. And I think that's quite a remarkable statistic. And your presentation really shows the absolute need for governments around the world to invest in public health as an essential pillar to improve the health and welfare of their citizens. So with that, I'm going to start with some of the questions that are flowing in. And for the first question, I'd like to just go to Nuala. Nuala has asking you, which Central and South American countries does the CDC provide TB technical or programmatic assistance for?
Sure, thanks, Dr. Martin. I'm going to ask, probably for a number of these questions, my wonderful colleague, Dr. Susan Maloney, who is the chief of our Global Tuberculosis branch, to chime in. Susan's been working on this for many years and can provide kind of nuanced texture and detail that I think is really important. So thank you for that question about activities in Central and South America, and I'm going to turn that over to Susan.
Yeah, hi. Good afternoon, everyone. It's nice to be here. I would say that for our global TB group, although Central and South America are not part of our priority or our focus countries, should still provide technical assistance and support in the form of guidelines, in the form of development of tools, in the form of virtual support. And we also have some research activities that are ongoing, especially in Mexico, which has a very strong connection with the U.S., where we're looking at multi-drug resistant TB and new ways of diagnosing TB in both adults and children.
Thank you very much, Dr. Maloney, and welcome, and thank you very much for joining us. The next question comes from Ali, and Ali asks about China and India. And Ali wants to know, China and India obviously have a much larger, economies, and than they had half a century ago. And the question is, what are these governments doing? What investments are they making to be able to address the TB and multi-drug resistant TB problems that they have within their countries?
Yeah, thanks for that question. I mean, I think Dr. Tomlinson overall made the comment that I think is very different than most other diseases, in that the domestic support for TB from most countries, and this is including China and India, is quite substantial, and it's probably, as he noted, at least 84% of the resources that go into TB in most countries, including China and India, are up around 84%. I'll say India and China have both been leaders in moving forward with the global TB epidemic, and they're both countries we work very closely with. India's actually been out front in terms of the NTB strategy and the global targets, and has taken on the challenge above other countries and said that they are planning to end TB in India by 2025. And they're taking very strong steps and putting a lot of resources into focusing on both active TB and now looking at preventing TB infections. In China as well, there's been a pivot and an increase in resources, especially around MDR TB, and we are working closely with them in a number of areas, including improving their surveillance systems, including their laboratory networks. They've taken on the SLMTA program and now are tailoring it to their own systems and developing their own rating systems that they're calling STAR. And we're also working with them to improve diagnostics for both adults and children.
Thank you very much, Dr. Maloney. The next question comes from Tara, and Tara wants to know the role of nurses in the CDC's response to preventing, detecting, and responding, treating TB. What's being done to include and strengthen the nursing community's capabilities, as they are such a vital part of the frontline workforce in health systems around the world? What's being done to work with nursing communities to address this pandemic?
So I'd say that if you think back to a few slides before we got to the question and answer session, you'll see the elements of TB basics, that's building and strengthening infection control systems. And nurses throughout the world, especially in sub-Saharan Africa, where there is significant TB-HIV co-infection, and parts of South and Southeast Asia, are the most significant cadre of service providers. And so in TB Basics, we seek to make a variety of changes that involve the management staff and the service providers within these facilities, and sort of communication to involvement of obtaining buy-in and support from nurses is absolutely critical. You know, if you think through what it means, and I'll just take the instance of TB-HIV co-infection here. If you were in an HIV clinic on the day of the week that HIV services are provided in a low resource, low income country in sub-Saharan Africa, you don't have an appointment for a visit necessarily. You have a day that you know clinic is provided, and perhaps a day that you've been assigned to come see your clinician or to come pick up a drug refill. You may wait in a waiting room, unfortunately, and we're trying with our programs to change this to the greatest degree possible. You may wait for 1 hour or 2 hours, or even in some instances 4 or 5 hours, and that's regrettable. We're trying to do better. But if that environment is one where there is poor air circulation, where there's overcrowding, where there's lots of people, where there are not protections and safeguards in place, and where there are people who are infected with TB, you are at risk for exposure. Nurses, to the extent that any change can be made in those service delivery settings, are absolutely integral as members of management, as service providers. And so I think that when we work with ministries of health and provincial and district health groups, and at the site, nurses have been a fundamental or foundational component of our activities.
Great, thank you very much.
Echo what Dr. Tomlinson said, and also to say that we see and we appreciate and we have lots of innovations that are being driven by nurses in our programs. Just one example is related to TB Basics, and this is in Zimbabwe, where we have had the nurses leading kind of the charge for developing a diploma program for infection control, which is very different. It's a practically based diploma program, which also has mini grants that we give to them to develop new ways to protect themselves and protect patients, which is just really driving forward the work that we're doing for TB infection control.
Great, thank you so much. Dr. Tomlinson, in your presentation, you mentioned a number of new drugs, because you know that this is a vital area that to address the pandemic. Can you share with us either of you can share information with regard to access the new drugs have for low-income communities? Are they affordable? Are they accessible to individuals who are particularly in marginalized low-income communities around the world?
I'm going to ask Dr. Maloney to respond to that, and I'll also ask her to reflect not just on the drugs that I mentioned, but on sort of a new combination of drugs that will be available in low and middle income settings for TB preventive treatment. So not just treatment of active disease, for which I mentioned the drugs that were to which you referred, but another regimen that should make TB preventive treatment much more widely accessible, and much more likely to be completed, and will have, I think, very significant effects for reduced TB incidence and also improving the lives of people living with HIV.
Yeah.
So, Dr. Maloney?
Yeah, so just to kind of reflect back on that, I think there's a big focus from the TB community and CDC as well with its partners to improve the access to these drugs for the community and partnering with the community to do that. There's lots of work being done on market shaping and work through the Stop TB partnership in our global drug facility. There are donation programs that have been developed to get these, especially I'll start first with active drugs and with MDR-TB drugs, to the poor patients and patients that don't have access. And I think we're seeing the numbers go up greatly. And if you look at the last global TB report from WHO, you'll see that we're getting more and more patients on MDR-TB treatment, and some of that can be attributed to improving the access and decreasing the cost of these drugs. Also, what was just announced at the International Union meeting that was held in India last week is the work that was done by many partners, including the USG, but also UNITAID, in trying to bring down the cost of rifapentine, which is one of the components of a new shorter TB preventive treatment regimen, which is called 3HP, which is a 12-dose regimen that's given over 3 months. And through kind of the focus and the efforts of many, many partners, we were able to have Sanofi bring down that price to something that we think is reasonable and improves access greatly. So the cost of the drug will now be down to about $15. It's a 60% decrease in that drug. And we will start, we're also in discussions right now with a generic producer for that rifapentine drugs and the combination. And so by 2020, we should be seeing these drugs be available in a generic market.
Thank you very much. One area that we didn't really hit on much, when the following question, following person wants to know, is regarding TB as a zoonotic disease and what percentage of TB is due to bovine TB. Can you share a little bit about spillover from animals to humans with regard to TB, how much of a problem this is? Is this a concern, and if so, what's the CDC doing about it?
Yeah, I'll take that one
Sure.
too. So this is an area that the CDC has been working in, and that we're partnering very actively with the Union International Union. It is an issue, and it does vary by geography. I can't tell you a percentage because it does vary, but somewhere between 5% and 10% in most cases, we can find zoonotic TB. We worked with the union to put together a zoonotic TB roadmap, which is available, and we can share with you about different approaches that countries can take based on their agricultural industry and based on their healthcare system. I think we're actively engaged with the One Health movement and finding ways that we can address this TB, this species of TB. Over.
Great. Thank you, Dr. Maloney. This question flips to the diagnostic side, and the questioner, we can maybe expand on some of the diagnostic information, Dr. Tomlinson, that you shared with us. What role the CDC is playing in scaling up new diagnostic groups, such as GeneX. Can you share with us a little bit about the work, either of you, about the work the CDC is doing a little bit more explicitly on expanding and scaling up new diagnostic opportunities?
Yeah. Sure. Again, I'll start with the focus on PEPFAR. I think Dr. Tomlinson had brought up CDC is actively engaged as one of the implementing partners in PEPFAR in rolling out, scaling up, analyzing, and optimizing the placement of expert machines throughout all the countries that we work on as part of PEPFAR. And this is in collaboration with other USG agencies like USAID and the Global Fund. I think we have a good contingent and are planning forward for this rollout of expert.
Thank you, Dr. Maloney. Sorry, go ahead.
At the same time, I think we're also actively engaged in evaluating and helping push for the use of other types of molecular diagnostics like UNHLM, and just to highlight that we were part of bringing the data to bear that has just helped change the WHO guidelines to expand the use of UNHLM in the diagnosis of TB, both in people living with HIV and those without.
And I would probably pivot and say, in addition to sort of development of new diagnostics, we've got a lot of sort of room to make up with doing better with what we already have. And so you've heard from Dr. Maloney about our attempts to optimize gene expert placement. You've heard or saw in some of my slides that we seek to test people living with HIV for tuberculosis and to make sure that people who are co-infected receive access to treatment as necessary. I think that one of the things that our agency is also actively working on, and you saw me refer to Elevate in India at the end of my presentation, but really is about the broader utilization of data by national tuberculosis programs. We've learned in the 16 years at CDC that we've worked on global HIV how important it is to collect, to review, to analyze, and to make decisions based on high quality, complete and accurate data, and that programs that do that can see a kind of success that is really not comparable to programs that don't. Now, global TB programs have received much fewer international donor resources than global TB programs, especially bilateral support. But we have sought to engage ministries of health, national TB programs, and others who focus on TB in countries to make sure that those resources, diagnostic and otherwise, are deployed to the areas of greatest need, where cases can be found, prevention and cure activities can be focused, and we deliver and work with countries to deliver effective programs who optimize impact and outcomes with the resource investment that is available.
And then if I could just riff off of Dr. Tomlinson to say that, or to underline again that molecular diagnostics and rolling them out are very important. But I think we've seen with some of the data, we've been disappointed with some of the data and not seeing the improvement that we had hoped in terms of turnaround times, in terms of any impact on TB incidence or TB mortality yet with expert. And I would say just as important as the molecular diagnostics and rolling them out is our understanding of the TB cascade, which we are always analyzing and understanding where we are losing patients in the TB cascade. Because if we diagnose a patient and then we don't bring them into treatment, then we will not realize the improvement in our molecular diagnostics. So it's very important to understand the infrastructure, and it's very important to understand your data about where your patients are and what the access is for your patients.
Wonderful, thank you. And that's a nice segue, Dr. Maloney, into the next question, which is an issue that really gets short shrift, but is a colossal hidden challenge in global health. And that's the issue of counterfeit drugs, black market drugs that kill thousands and thousands of people around the world. And perhaps you can share with the audience what the CDC is doing to educate, train, or reduce the incidence and use of black market drugs around the world. And that you may or may not be able to answer that question, but.
Well, I can say that in my own personal experience, when I was a scientist on the ground, I've done a number of studies on this, so I know that it exists, and it exists in many countries. We can work with national programs to help put in place, and we do work with national programs to put into place kind of safeguards and new laws and policies that can try to stop bringing the counterfeit drugs into the market. We also work very closely with our sister agency, the FDA, which has a big role in kind of helping with addressing the counterfeit drug problem.
Great. Thank you, Dr. Maloney. We certainly hope, I know ASD, American Society of Tropical Medicine, has been very interested in this, and I hope that countries work together to pay more attention to stopping this, which kills so many people and robs some of the poorest people in the world of their valuable resources. Then the next question really kind of comes from Nirmal and wants to really delve more deeply into the issue of compliance amongst patients. I know, Dr. Tomlinson, you spoke about, and both of you have spoken about the need to shorten treatment courses and reduce side effects for drugs, but can you share anything else that's being done to addressing and utilizing social interventions to improve adherence to treatment regimes?
Okay, I'll start. I mean, adherence is a major issue for all of us. I think we'd like to use adherence rather than compliance and kind of take a little bit of the sting of that word away. But just to say that we've been working in a number of countries at different ways that we can help. I mean, one thing that we can do, of course, is to make the healthcare system more patient-friendly and to make it easier for patients to be able to take their medicines and to access their medicines. And we can take a lesson from PEPFAR on that, and we are taking those lessons on how we can bring the care closer to patients and how we can visit patients in the home or their community or use community resources when we can to provide the medications. We've also been looking for ways to kind of help increase the ways that we can interact with patients without making them come to healthcare facilities. So in India, we were working with the Indians on a 99 dots program, which is basically a way for patients to be able to call into a call center when they take their medication so that we can keep track of that and have ways to kind of flag patients that might be having issues. We also worked on developing with a behavioral institute ways that we can help to follow up with patients that we think are having adverse events, which is one of the major reasons that patients have problems with adherence.
So I'd also chime in and say that from our broader global work as an agency and as the Division of Global HIV and Tuberculosis, we really have learned that that patients or clients taking different kinds of medicine can be very good at adhering. And of course, there are legitimate concerns. I mean, if regimens or drugs aren't well tolerated, if there's a likelihood or a high likelihood of adverse events, those are significant and need to be attended to. But there has been a sort of paradigmatic difference, I think, in the global HIV community and in the global TB community, which is pretty clear, or has been over the last few years, and it's something that we are trying to use our knowledge and experience to bridge that gap or maybe make paradigmatic change. And that is, in the global HIV world, we have moved towards models of differentiated service delivery where, just as Dr. Maloney mentioned, we seek to provide services that are convenient to and hospitable to and for clients, that make it easier for them to receive clinical services, but also drug pickups. Part of that could be the community-based service delivery, initiating on the same day as someone is diagnosed, making sure that you can pick up 3 months of drug at one time or 6 months, using adherence groups so that 12 people in the community can band together to support one another in their adherence to a medication, but only one of those people has to walk 10 kilometers each month to pick up the drug supply for all 12 members, reducing burden from monthly visits to the clinic to once per year. We've learned those things in the HIV arena and are trying to figure out what might make sense and what might be practicable in the global TB arena. And there is this idea to move from daily observed therapy into something that invokes or utilizes the tenets of what I just mentioned. And so I think just recognizing that, applying lessons learned from other areas, recognizing legitimate needs for ongoing monitoring for poor adherence and for adverse events, and then incorporating that into a package that makes sense for patients. I think that we've learned that patients can be motivated to achieve the outcomes that we and they want if we make it a little easier for them to do so.
And so right now within the PEPFAR program, we are kind of learning and finding ways to build the TPT regimens that we need into the differentiated service models for HIV treatment. And again, we have varied models that can be tailored to the needs of localities and communities, and are going pretty well. So.
Great. So in the last couple of minutes, thank you to both of you. If there are any closing comments that you'd like to make in terms of our audience, our global health audience around the world that's listening to this webinar, Can you share with them things that they can do, arguments that they can make to their governments, their communities to invest in TB prevention, detection, and treatment?
So I'll start, and then I'll actually invite Dr. Maloney to conclude us today. And so I would say that there are a few things, and these were particularly important during and have been particularly important after the UN high-level meeting on TB that took place in 2018. And so I think first and foremost, political will is important. And so if you were asking, and it's not just political will among political leaders, it's actually will among members of government, national TB program directors, those who are providing services at the provincial, the district, or the site level. We know that when expectations are high and there is a provision of basic resources and there is a utilization of information that's readily available or just one step beyond readily available, the impact can be great. I think that the global tuberculosis community has lagged behind some of its counterpart for other vertical programs, and whether it's global HIV or global malaria, there has been a call to action among advocates, among service providers, to corral people who have been affected or living with tuberculosis, to make sure that there is encouragement that forward movement happens at an accelerated pace, that big gains are expected, and that once we establish that momentum, we maintain the inertia to see it through to completion. Secondly, I'd say data matters. And one of the things that we believe is that every dollar that we, as a U.S. government agency using U.S. government taxpayer resources, or any other donor or any national program invests into their TB activities, needs to be optimally utilized. The best way for us to do that is to be able to adequately, sufficiently characterize national and subnational TB epidemics, to know where to focus our prevention, our treatment, and other activities for tuberculosis, and to achieve the sort of greatest returns on our investment. I think that ensuring with partners throughout the U.S. government and beyond that members of national TB programs have expectations for regular, routine collection of high-quality data, utilization of that data on a frequent basis, not an episodic basis once every blue moon, to determine what's working well, where in that TB cascade from finding to cure patients are. We can identify the best practices, we can figure out what's working, we can disseminate those more broadly and more quickly. We can also identify where things are going wrong and try and redress those problems with appropriate intervention. And I'll give the last word to Dr. Maloney.
I guess I would just echo what Dr. Tomlinson said, and also to say, you know, go out and think TB and say TB anytime that you can. This is it's such an exciting time in TB. There's lots of things going on. There's many new developments in drugs and strategies, and to think data, and that will help us to have educated advocacy and also to engage our patients and to engage our communities in new and innovative ways to learn from some of the other diseases and just to push forward with the momentum that we have.
And I forgot what I think is actually the third tool, not quite the final word, the third sort of part of the stool, third leg of the stool, and that would be accountability. And so as much as we ask for political and other kinds of will and for the real demonstration of that, as much as we want programs of all kinds to use complete and accurate and regularly reported data to drive their decision making, to monitor progress, to improve quality when issues are observed, we want you to hold us and national TB programs accountable. And so thankfully, there has been the sort of collective effort to develop a multi-sector accountability framework to which I referred in my presentation. I think real adoption of that framework and making sure that it has, to the greatest extent possible, teeth, means that it will be utilized and increases the likelihood that change will materialize.
And if you're working at individual country levels, there's a kind of a corresponding document that's from Stop TB Partnership, which has the targets, the accountability targets by country. And I think thinking about it in that way and having a country own whatever their part of the target is for 2022 and beyond is going to be important. It's going to be a way to push people forward.
Thank you, Dr. Martin.
Well,
that's it for us at CDC.
Wonderful. Well, much thanks to both of you, Dr. Hank Tomlinson and Dr. Susan Maloney. We thank you both from us here in Washington, D.C. And in fact, I think what you both described is the incredible work that all of you do at the Centers for Disease Control and Prevention to improve the health of people in the U.S. and around the world. You all work tirelessly to that end. And clearly, from our view, investing in the CDC is a wise investment for all of us. So thank you very much for the work that you're doing to end TB. And I think, folks, what we've heard is that ending TB is a mission possible. Not impossible, it's a mission possible. And it's for all of us, whether we're part of the TB community or not, we are actually all part of that community that is needed to go to communities, go to our elected leaders, and ensure that we make the investments to end one of the top 10 killers in the world. It can be done, and we can do it. So I'd like to thank our team here, Jenna, Dalal, and Monica, for putting on another one of our webinars. I invite you folks to come to our conference next April 17th to the 20th in Washington, D.C., where you'll meet leaders from the CDC, NIH, and individuals from around the world who are working to deal with some of the biggest global health challenges we face. Thank you very much for joining us today. I'm Dr. Keith Martin, Executive Director for the Consortium of Universities for Global Health. Have a great day.